So I apologize, you have to listen to me 2 times in a row, but the schedule needed to be rearranged like that. And this topic is an important one. Meningitis is probably the most serious complication of bacterial and fungal sepsis. It's one we worry about. First of all, meningitis is pretty common among newborn babies, with incidences ranging from 10 to 25%. But the main problem we worry about it is that morbidity, neurodevelopmental handicaps, cerebral palsy, are seen in about 50% of survivors of neonatal meningitis. Unlike the treatment of meningitis in older children, which commonly involves Decadron, the treatment of neonatal meningitis has not changed during my lifetime. We give antibiotics, we use supportive therapy, we may need to ventilate a baby, but we treat and we hope for the best. I think in the near future that's going to change because we have a much better understanding now of the pathophysiology of meningitis and the pathogenesis of the brain injury that's seen with meningitis. So what I'd like to do over the next 45 minutes or so is to bring you up to date with 2012 concepts in terms of diagnosis and management of babies with meningitis, and present some of those newer concepts that have to do with the pathogenesis of brain injury. And this case is an old case, and you see the baby's name is GS, which stands for George Simbrunner. I've used this in IPOKRaTES before, but the rest of the information is all new. He was not a 2.6 kilogram male infant born to a 23-year-old gravid 6 power 5 woman at 36 weeks gestation, complicated by preterm premature rupture membranes. There was rupture membranes for 18 hours prior to delivery, so there was both prolonged rupture and preterm rupture. The mother was afebrile to 2 hours prior to delivery when she got a temperature of 37.8. A vaginal culture was done at 35 weeks gestation, which is positive for group streptococcus, and intrapartum ampicillin was administered. The baby was delivered by cesarean section, had APGAR scores of 7 and 8, and he was sent to the NICU because of some respiratory distress. The estimated gestational age was 36 weeks. The initial chest x-ray appeared wet looking, as typically babies look at that time. The symptoms resolved, as many babies do, by 6 hours. However, there's a debate of whether antibiotics are indicated and if a lumbar puncture should be done. So this is going to be a multiple choice for you, and you have to choose A, B, or C. I'm sorry, those are your only choices. I'm sure there's a D. I just didn't think of it. So choice A is observation, blood culture, and CBC optional. Choice B is antibiotics following a blood culture, CBC, and lumbar puncture. And choice C is antibiotics following a blood culture and CBC, but no blood culture. So you got to make a choice. How many would choose just to observe this baby? Just choose A. Okay, so you listen to my last lecture where I said observation is perfectly fine, even in a late preterm baby. How many would choose B and do the lumbar puncture in a kid like this? How many are doing frequent lumbar punctures? I don't see anybody. So the rest of you are all C people? Okay, and I think the correct answers really are A or C. I think you could have the option of doing either. So let me address some fundamental questions. First being, should a lumbar puncture be part of the sepsis work in a baby who looks totally well to you, in other words, asymptomatic, who you're suspecting sepsis because of risk factors? And here there's 2 bits of conflicting data. The first is from a study published 14 years ago by Tom Wiswell. And this is a retrospective study of babies that were in the armed forces, whose parents were in the armed forces, who actually had neonatal meningitis. He came up with a population of 43 babies. 12 out of the 43 had negative blood cultures. And you're going to hear that number over and over again during this lecture, that blood cultures are only positive in babies with meningitis about 60% of the time. So you cannot use a blood culture to decide who needs to have a lumbar puncture. Out of those 43, again, retrospective chart review, 7 were asymptomatic. And as it turns out, 4 of these 7 babies had negative blood cultures. So if you look at this study, you say, oh my God, a baby can be asymptomatic, have a negative blood culture and still have meningitis. That's one side of the story. And this is the other side. These are 3 studies published in the 1990s looking at a similar question, looking at a group of babies born to mothers where there were risk factors for sepsis, and the babies were symptomatic, or no risk factors for sepsis and symptomatic babies, or risk factors for sepsis and asymptomatic babies. And what you're looking at here is the incidence of meningitis, and you can see the only times there were meningitis in this, again, all retrospective chart reviews, were in symptomatic babies. There were no babies born to mothers in the 8 who were asymptomatic, even when there were risk factors present. So this represents a population of thousands and thousands of babies. My conclusion from these studies is that meningitis occurs rarely, or if ever, in a baby who looks well to you at the time of birth. How about the symptomatic baby now? The baby who's not well at 6 hours, but it continues to have signs of respiratory distress or cardiovascular instability. Should we do an LP routinely on those babies? So I started off my lecture by saying meningitis is pretty common, seen in 10 to 25% of babies who are bacteremic or fungemic. Again, the studies that are out there say about 1/3 of infants with meningitis have negative blood cultures. Again, you can't use a blood culture to make a decision about lumbar puncture. But it's interesting that the 2010 guidelines put out by the Center for Disease Control, these are the Group B streptococcal guidelines, recommend a lumbar puncture in every symptomatic infant with suspected sepsis. I think that's the wrong recommendation because it would mean doing a lumbar puncture on lots of infants who clearly have a non-infectious condition. But that is the official recommendation of the CDC. And what I would say is the LP ought to be reserved for selected high-risk infants, which I'll show you in a second. And the third question, how about babies with late-onset sepsis? These are obviously all symptomatic babies. Should we do a lumbar puncture on those babies? And this is the only study I'm aware of by the NICHD Research Network. It's a retrospective study where they had almost 10,000 babies. 2/3 of them had a blood culture, and about half of these babies also had a lumbar puncture beyond day 3. This is late-onset sepsis. Meningitis was present in about 5% of babies with late-onset sepsis, but again, they only did lumbar puncture on about half the babies that had blood culture, so the incidence of meningitis is probably higher than that. 1/3 of the infants with meningitis had negative blood cultures, so again, the same message, blood cultures are frequently negative, and babies with meningitis had higher mortality and morbidity. So looking at all that data, I think it's very unlikely that meningitis occurs in an asymptomatic baby, and I would not do a lumbar puncture on that infant. I would use an LP very selectively, either in babies with a positive blood culture or a high probability of bacterial fungal sepsis, or infants that do not respond to conventional antibiotic treatment in the usual fashion, even when blood cultures are negative. Well, the initial sepsis screen is negative, and the care providers did do a lumbar puncture. So you're going to be asked to make a decision. So there are 24 white cells present in lumbar puncture. About 1/3 were neutrophils. Protein was 120. Glucose was 45. There's no concurrent serum glucose obtained. The gram stain is pending. Is this normal or is this abnormal? How many think they would use this as a normal lumbar puncture in a baby at 36 weeks? How many normals? All right, how many would consider it abnormal? The normals in this audience at least win. So I'm going to show you how I interpret those data. Before I do that, I want to point out that there's always a physiologic movement of white blood cells from the bloodstream into the central nervous system, into the CSF. And it appears to occur at the choroid plexus. So on this little cartoon over here, here's a blood vessel. These are mainly mononuclear white blood cells. Here are the endothelial cells. Here's the stroma, and here's the CSF. And it's interesting that the endothelium of the choroid plexus is fenestrated. There are holes between the endothelium. So it's easy for white blood cells, or easier for white blood cells, to get from the bloodstream into the CSF. So there's always some movement of white blood cells, and it's a receptor-mediated process using ligands called selectins and integrins, but they allow the white cell to move into the CSF. And if you look at what's present in CSF in totally healthy individuals, most of them are T cells with an increased percentage of CD4 positive cells. About 5% are monocytes, 1% are B cells, and neutrophils, at least in the older child or adult, are relatively rare, a little more common in newborn babies. So if you look at the data and say, what is a normal CSF? If you go back to 1976, there's a very famous study by Sarf, who did lumbar punctures on healthy babies or babies without obvious infection, and came up with numbers that 30 cells are normal in the CSF, or proteins up to 200 can be normal. The problem is, in that study, he did not exclude babies that had traumatic lumbar puncture, and did not exclude babies either with congenital infections or viral illnesses. So what you see on this slide are 5 studies which have looked at that question of what the CSF should look like in a healthy term or preterm infant. Just want to point out a couple of these things. All these studies excluded traumatic lumbar puncture. Some studies would not accept more than 500 cells present in the CSF. The study by Nascimento was actually cisternal puncture, so it was not really a lumbar puncture. But you can look at the data, and it's pretty consistent, that in both term and preterm babies, the mean number of white blood cells, which is shown in black, is almost always less than 10 white blood cells. If you look at 2 standard deviations from the mean, they can be as high as 20 white cells, but mostly 2 standard deviations is less than 20 white blood cells. And if you look at the protein concentrations, look at the preterm babies, it can be higher, but almost all term babies have protein concentrations in the CSF less than 100 milligrams per DL. Therefore, the way I interpret those data, more than 15 cells in a spinal fluid sample should be considered suspect, at least think about meningitis, and 2 standard deviations from the mean in a term or preterm baby, for me, is 20, and most of those cells should be mononuclear. So I make the diagnosis in a clean tap when I see 20 cells. CSF glucoses in babies are similar to older children, and adults should be 70 to 80% of the simultaneously drawn plasma or serum glucose. Protein concentrations in a term baby should not exceed 100 milligrams per DL, but in preterm babies, we all know that protein concentrations can be a lot higher. There are a few other confounding variables. How about if you take your sample and it doesn't get to the laboratory quickly? People have looked at the issue of delay in analysis, and when it's been more than 2 hours, both white cells and glucose decrease significantly. The white cells going down makes it look like the baby does not have meningitis. Glucose going down can make it look like the baby does have meningitis. Pre-treatment with antibiotics, some babies get antibiotics and then you give us an LP, does not modify the counts in CSF, but it does increase CSF glucose levels and lowers protein concentrations. So pre-treatment, say 12 hours before, may make it look like the baby does not have meningitis. I used to use a formula for adjusting traumatic taps and look at the red cell count and the white cell count in peripheral blood and make sort of an adjustment in CSF. It's not worth doing that. It's been looked at in at least one study. It decreases the sensitivity with marginal gain in specificity, so I never adjust for a traumatic tap. And if you see bands in there, it's interesting, but it's sort of meaningless. Band forms do not predict meningitis in CSF. So let me turn my attention to babies who actually had meningitis. I'm going to show you 2 studies. This is the first study of 95 babies who were more than 34 weeks gestation. Once again, only 2/3 of the babies had positive blood cultures. It turns out the babies without meningitis had a mean white count of 6, so under 10. Those with meningitis had mean white counts of almost 500. The protein and glucoses were highly variable. But the bottom line message from this study is that meningitis can occur with a normal white blood count, normal protein, and a normal glucose level. Let me show you the data from this study. So they broke down their data for white blood counts, glucose, and protein into different ranges. So for white counts, they looked at 1 to 8, 9 to 21, 22 to 100, and greater than 100. Glucose, they're looking at less than 20 or 20 to 60, and protein, they're looking at 3 different ranges. And interestingly, the best combinations of sensitivity and specificity for at least the white counts were white counts more than 20, sort of what I just told you, and for proteins greater than 120. Again, there's some preterm babies in this study. But the marker with the highest specificity by far is shown over here, that hypoglycemia, low glucose concentration in CSF, had by far the best specificity for meningitis. About 13% of the babies with meningitis had white counts less than 21. Again, it's my cutoff for meningitis in babies. There were 12 infants who had white counts between 1 and 13, perfectly acceptable group. And if you look at the protein concentrations, 6 to 12 of those babies had protein concentrations less than 100, and glucose concentrations were normal in 12 out of 12. Again, emphasizing that a CSF can be completely normal looking in terms of white counts, protein, and glucose, and the baby can actually grow something out of the CSF. This is done by the same group of investigators, but looks at babies who are now 34 weeks gestation or less. Again, 95 babies. 30% of the babies had negative blood cultures, the same recurrent theme. The pathogens they got in the study were sort of interesting, not the ones that I usually associate with meningitis commonly, and those were Staphylococcus aureus and Candida. The mean white blood counts were 6 in the healthy babies, 110 in the babies with meningitis, a little lower than we just saw before. Protein concentrations in babies with meningitis were higher, and glucose concentrations were a little bit lower. And these are their data spread out in a similar fashion, looking at ranges. And it turns out for the white blood count, the best combination of sensitivity and specificity in the preterm population were white counts more than 25. They looked at which markers were best predictors of meningitis, white blood count, protein, or glucose. And to do that, they did, again, ROC curves, receiver operator characteristic curves, which is a plot of sensitivity versus specificity. And again, we're looking at the area under the ROC curve, and the best area was for white blood count, followed by protein, followed by glucose. The best specificity was, again, clearly hypoglycemia, low CSF glucose, but the positive predictive accuracy for all these things was incredibly bad. So whether you had low glucose or higher white count or higher protein concentrations, they all had a bad positive predictive accuracy for saying a baby actually had meningitis. And lastly, this is a series which looked at babies with fungal meningitis. Again, blood cultures were only positive about 63% of the time, negative in about a third. And they found normal CSF parameters defined by SARF. Remember, SARF was that very old study that had a lot of traumatic taps, but they have found normal CSF parameters in 43% of the babies that ended up having Candida meningitis. This is a study which looks at the differences between gram-positive and gram-negative meningitis, looking at white blood counts over here, showing that white blood counts tend to be higher with gram-negative meningitis. Also, red cell counts tend to be higher with gram-negative meningitis than gram-positive meningitis. So let's switch topics away from diagnosis to a little bit of the talk about pathogenesis of meningitis and the pathogenesis of the brain injury that occurs with meningitis. Whether you're a one-day-old baby or a 99-year-old elderly person, the pathogenesis or pathophysiology of meningitis is basically the same. It starts with nasopharyngeal colonization with subsequent seeding CSF. The CSF multiplies and spreads in the subarachnoid and ventricular systems. There's progression of inflammation with production of all kinds of nasty substances, free radicals, and excitotoxic amino acids. And finally, there's neuronal damage. So in newborns, meningitis starts with nasopharyngeal colonization. The baby usually comes out of an infected environment or becomes colonized in the nursery. We know that bacteria are skilled at sticking to the nasopharynx. They have pili and fimbria, which are able to stick to the epithelial cells in the nasopharynx. And they are able to penetrate either between or through the epithelial cells lining the nasopharynx. In a newborn baby, once the bacteria is in the bloodstream, there's very little the newborn infant can do to eradicate that bacteria. As you know, sepsis and meningitis occur in babies who lack antibody against the offending pathogen. So whether it's E. coli or group B streptococcus, the mother either doesn't have antibody or the baby's been born so prematurely they've never received the antibody. And in that circumstance where there's no antibody, the infant has to rely upon the innate immune system to fight off that infection. As you know, immunity to bacterial infections is divided into adaptive immunity, which are the T cells and B cells. This requires having seen the pathogen sometime in the past. Those are memory responses. For the first time response, there's a whole variety of cells that can be involved in the response. It's called innate immunity. But phagocytic cells and dendritic cells and neutrophils are the prime ways babies respond, along with things like serum complement, which is part of the innate immune system. To get into the CSF, it has to cross into the brain through barriers. And there's two potential barriers bacteria have to get across from the bloodstream into the brain's cerebrospinal fluid. One is called the blood-brain barrier, and the second is called the blood-CSF barrier. And I'd like to illustrate some of the differences. The blood-CSF barrier really is the choroid plexus. The choroid plexus are epithelial cells arranged around villi containing vascular stroma. They line most of the ventricular system and secrete CSF, finally going over in the subarachnoid space and being reabsorbed by the arachnoid villi. And as I've just said, it's easier for cells to get across the choroid plexus because the choroid plexus is lined with endothelial cells, which are fenestrated. There's holes between the cells. So whether it's white cells there or bacteria there, they can get into CSF a little bit more easily. The other barrier to penetration of the brain is the blood-brain barrier, and this looks at the blood supply to the brain. Blood supply to the brain, as you know, comes mainly from the internal carotid arteries and the vertebral arteries, ultimately which form the circle of Willis, giving rise to the anterior, middle, and posterior cerebral arteries. These arteries are different because they're lined by endothelial cells, which have very tight junctions. They're not fenestrated, and it's much more difficult for bacteria to penetrate them. In fact, not only do they have these tight junctions, but they have other kinds of cells, parasites and astrocytes and neurons, and it's a very well-defined basement membrane. So it's much harder for either a white blood cell or bacteria to penetrate these vessels. Therefore, when you ask the question, how does bacteria get across the blood-brain barrier? It probably does it, at least it's been looked at, by a transcellular mechanism. The bacteria are actually carried through the cells and then enter the central nervous system. And it's a receptor-mediator process. For me, it's pretty interesting to realize that endothelial cells actually have, and I don't know the reason for this, receptor for bacteria. So once an endothelial cell binds to the bacteria, it uptakes that bacteria into a vacuole, transfers it to the other side of the cell, and where the bacteria can exit, or through a process called exocytosis. So it's a receptor-mediator process through the cell that gets bacteria from the bloodstream and into the cerebrospinal fluid. Once the bacteria are in CSF, there's almost nothing that can be done to help fight off the bacteria. People call it a localized area of immunodeficiency. Under physiologic conditions, there's a few white blood cells, mostly mononuclear. Clearly, they can't fight off the bacteria that are there. The replication and autolysis, the destruction of bacteria just from growing fast and dying off, releases bacterial components. If you're gram-negative, it releases endotoxin, lipopolysaccharide. Gram-positives release other components of the cell wall. And the materials that are released are called PAMPs, P-A-M-P-S. These are pathogen-associated molecular patterns. And it's those PAMPs, those substances, which initiate the inflammatory response in the central nervous system by binding to receptors. And the most common kind of receptor are toll-like receptors. Toll is derived from a German word, first identified in Drosophila. But toll-like receptors are found on the surface of cells. There's a whole variety of toll-like receptors, and some toll-like receptors are actually found within the cell, bound to phagolysosomes. In general, toll-like receptor 2 tends to bind gram-positive organisms. Toll-like receptor 4 binds the gram-negative pathogens. Once that occurs on the surface of the cell, there's a series of reactions which take place, which ultimately result in the inflammatory response. Let me just show you very briefly what's happening. Inside the cytoplasm of cells is a nuclear transcription factor. That transcription factor is called nuclear factor kappa beta. It's hard to see. It's shown in the green circle over here and these two blue dots over here. And as it sits in the cell, it's bound to an inhibitory substance. That inhibitory substance is called I-kappa beta. There's a variety of inhibitory substances in the cytoplasm. And when the signal comes in through the toll-like receptors, here's toll-like receptor 4, a series of enzymatic reactions occur which ultimately destroy that inhibitory substance which is binding the nuclear transcription factor, then allowing it to move into the nucleus of the cell, bind to DNA response elements, and it's that binding to DNA response elements which ultimately results in the production of cytokines, chemokines, and other kinds of inflammatory substances. So how about neuronal injury? This is an illustration from an article on cell death which appeared about 2 years ago in New England Journal of Medicine, looking at the way neurons die, either through apoptosis, sort of programmed cell death, necrosis, and autophagy, which is exhaustion of substrates for cell growth. The two principal ways cells die in meningitis are thought to be necrosis and apoptosis. I think about apoptosis as sort of like suicide. The cell makes up its own mind, decides it's going to die, and then uses energy to destroy itself, where necrosis is cell death, which is more like homicide. It's cell death which is occurring from the outside. So, cell death is necrosis secondary to ischemia and cytokines and excitatory amino acids like glutamate, reactive oxygen species, and toxins. And apoptosis is a receptor-mediated process, also mediated somewhat by mitochondria. So just to distinguish between the two in terms of a process, apoptosis can occur from either an external signal or an internal signal. It's an energy-dependent process. The cell has to make up its mind and use energy to die. It involves signal cells, which are then engulfed by macrophages, and almost no inflammatory response. Where necrosis happens because of events which happen outside the cell, ischemia, toxins, radiation. It's not an energy-dependent process. It affects a group of cells. The cells swell and release their content into the surrounding, and there's a marked inflammatory response as a result. This is looking at cellular apoptosis, just to make the point that there are two different pathways. One is death receptor mediated by TNF or TNF-related molecules. The other is by release of substances from mitochondria, specifically cytochrome C. Ultimately, they have a common pathway that involves caspases, and caspases are involved in causing this programmed cell death or apoptosis. And the other way is necrosis. And again, necrosis is initiated by events outside the cell, not by the cell itself. And up here, you see the nuclear transcription factor shown over here, nuclear factor kappa beta, which when it binds to DNA response elements, releases cytokines and chemokines and all kinds of adhesion molecules, releasing ultimately proteolytic enzymes, matrix metalloproteases, which cause degradation of the extracellular matrix. Also releases oxidants, including peroxine nitrate. Peroxine nitrates can cause lipid peroxidation of the cellular membrane, can also cause direct damage to DNA in the cell, which causes what's known as PARP, P-A-R-P activation. PARP stands for poly-ADP ribose polymerase. It consumes energy, and ultimately the cells will die from energy depletion. But through both methods, either through lipid peroxidation or DNA damage, the ultimate conclusion is cell death. Well, to go on now to management. Our baby started on broad-spectrum antibiotics. He's a little obtunded. Vital signs in urine output are normal. Head ultrasound reveals slit-like ventricles smaller than are normally seen. They're talking about cerebral edema. So which of the following interventions is indicated? This is another multiple choice question for you. Your choices are fluid restriction, intravenous Decadron, intravenous mannitol or glycerol. I'll give you a choice there, or none of the above. And you can pick more than one. So this is a multiple choice. So how many of you would normally in a baby with suspected cerebral edema choose fluid restriction? Okay, a few hands are going up there, maybe 5 or 10. Decadron? Nah, I think we've shown that's probably not a good thing for newborn babies. Mannitol or glycerol? How many have ever used that in part of the clinical practice? I'll show you a data in a little second. And my response to this would be none of the above. So those of you, there we go. Well, I think about 75% are choosing none of the above. If you think about increased intracranial pressure in meningitis, you can get it from, obviously, from cerebral edema. A rare complication is hydrocephalus with obstruction of flow, either from ventriculitis or arachnoiditis. I've seen a few babies in my lifetime that have subdural empyemas or effusions related to meningitis. Not as common anymore, maybe because we treated sooner. And lastly, as you know, babies can get water intoxication from SIADH, the syndrome of inappropriate secretion of antidiuretic hormone. When it comes to cerebral edema and meningitis, there are 4 kinds which are relevant: vasogenic edema, cytotoxic edema, interstitial edema, and osmotic edema. So vasogenic edema results in an increase in brain extracellular fluid that occurs either because the vessels are leaky, increased permeability of the blood-brain barrier, increased transmural capillary pressure, or retention of fluid in the interstitial space. Cytotoxic edema is caused by failure of sodium-potassium ATPase mechanisms, especially in a region of ischemia, and is mediated by release of toxic factors from white cells or bacteria. Osmotic edema is due to low protein or low sodium. Interstitial edema occurs with, more commonly with obstructive hydrocephalus and decreased clearance of CSF by arachnoid villi. In adults, increased intracranial pressure is a big deal because the skull is rigid, and increased intracranial pressure can cause herniation. Also can occur in younger children, but the skull of the neonate, fortunately, is more expandable. Cerebral edema is unlikely to cause herniation and result in brain injury, at least from that mechanism. But most importantly, brain injury is likely to occur when arterial blood pressure perfusion is not in normal range. So maintenance of normal blood pressure ought to be the goal, or your goal, of babies who have proven or suspected meningitis. So these are the possibilities of management of cerebral edema: fluid restriction, correction of SIADH, Decadron, hyperosmolar agents, and hyperventilation. And for me, the most important, again, is maintenance of cerebral perfusion pressure, which is mean arterial pressure minus intracranial pressure. Fluid management is pretty controversial. Too much fluid is going to contribute to cerebral edema. Too little fluid contribute to hypotension and poor cerebral perfusion. There have been 3 randomized trials of restricted versus maintenance fluid in children. There are a few newborn babies in those studies. They've been done in countries where mortality rate was very high, and patients sought help very late in the course of disease. And unfortunately, the data are inconclusive about fluid restriction. For me, the initial decisions about fluid should include an assessment about the baby's clinical status. Is the baby fluid overloaded or underperfused? What do the electrolytes look like? Is there SIADH present? Is there adequate urine output? In the absence of hyponatremia and SIADH and normal renal function, I just give all those babies maintenance fluids. I do not do fluid restriction. If the baby's in shock, clearly perfusion pressures is important, then fluid resuscitation or pressors are important. Infants with SIADH ought to be fluid restricted. If a baby's well perfused and hemodynamically stable, and you think there's documented cerebral edema, then you might want to consider fluid restriction in that specific circumstance. Diagnosis of cerebral edema: I can't remember the last time I measured intracranial pressure during a lumbar puncture. Maybe Terry does in her practice. We don't do it generally in New York. We rely upon ultrasound or CT or MRI scan, usually ultrasound. And clinically, babies with cerebral edema have a full fontanelle, separated cranial sutures, and they're often have a decreased level of consciousness. How about mannitol? Mannitol has been used for probably more than 30 years to treat cerebral edema. It's a sugar alcohol. It's filtered by the kidney. It creates an osmotic gradient, so it's drawing in fluid from the central nervous system across the blood-brain barrier. In experimental meningitis, it does lower intracranial pressure, but where it's been used clinically, it's caused lots of problems, including acute renal failure, hyponatremia, other electrolyte imbalances, and volume overload, including pulmonary edema. There's no randomized trials in babies with meningitis, and most experts in this area do not recommend the use of mannitol. Glycerol is interesting. There's a little bit of data on glycerol. People think glycerol is safe because if you're chewing gum, you're probably also taking in glycerol into your body. There was one randomized controlled trial on children, but not neonates. It was a comparison of oral glycerol versus dexamethasone. And the bottom line is that glycerol reduced neurological handicaps. It was well tolerated. Glycerol may improve hypovolemia. It may be a free radical scavenger, but there's no data that I know of on neonates with meningitis. And Decadron, the data are very clear. If it's H. influenza meningitis in an older child or possibly pneumococcal meningitis, Decadron is indicated. It must be given with or before the antibiotic. In animal studies, Decadron reduces vancomycin penetration in the CSF and delayed sterilization. So if you have a late onset meningitis and you're giving vancomycin, Decadron is probably contraindicated. There's only been one randomized trial in babies, no benefit, no proven benefit. GBS was a rare pathogen in that study, and it's fair to say that Decadron is no longer recommended for meningitis. Again, the main intervention to lessen neuronal injury, I think, is maintain cerebral perfusion, administer antimicrobial agents. But there are theoretical ways. When I started off this lecture, I talked about new ways of thinking about the pathogenesis of brain injury. People are looking at ways of resetting or inhibiting the inflammatory response and cytokine and coagulation pathways. These have all been, a lot of these have been extensively tested in animals, but not made it to humans. For example, you can inhibit the nuclear transcription factor, nuclear factor kappa beta. TNF-alpha is secreted in its pro form, and there are inhibitors against the conversion of TNF-alpha, pro-TNF-alpha to TNF-alpha by inhibiting the TNF-alpha converting enzyme. There are TNF monoclonal blocking antibodies, which have been used, again, with success in experimental animals. And there are also a variety of cytokine receptor blocking antibodies, like IL-1 receptor antagonists. Modulation of coagulation and inflammation has been looked at mainly in the adult literature. Activated protein C may have some benefit in adults, but there are absolutely no studies in children, and in fact in neonates, to show that any modification inhibiting histamine, prostaglandins, bradykinin, the complement system, or any of the coagulation substances has any proven benefit. And with regard to antibiotics, which is our mainstay of treatment, the goal should be obvious to you, is to achieve a bactericidal concentration of an appropriate antibiotic in the CSF so as to sterilize spinal fluid as quickly as possible. There are three variables or factors that affect the bactericidal activity. One is the penetration of the antibiotic, the ratio between the CSF and the blood concentration. The secondly is the activity of the antibiotic in CSF itself. And finally, the concentration of the antibiotic. You may have an antibiotic that's there, but found in so low concentrations it cannot eradicate the bacteria. Once it's in CSF, or the factors that influence penetration of antibiotics into CSF, including how protein-bound the antibiotic is in the bloodstream. For example, ceftriaxone is highly protein-bound. What's the lipid solubility? Lipid-soluble antibiotics like rifampin get in easier. What's the molecular weight? Low molecular weight substances get into CSF easier. And is there meningeal inflammation? Because meningeal inflammation allows penetration of ampicillin, penicillin, the cephalosporins, and vancomycin to get into CSF a lot more easily and does not affect any of the lipophilic antibiotics like rifampin. There are also factors in CSF which may limit the effectiveness of the antibiotic. So low pH may limit the effectiveness of aminoglycosides. Highly protein-bound antibiotics, there's a lot of protein in CSF, may limit concentrations and may decrease the effectiveness of antibiotics. If a bacteria is very slow growing, it may limit the effectiveness of antibiotics, especially beta-lactams, which depend on brisk bacterial growth. Some antibiotics are metabolized to less effective compounds, and sometimes there's so much bacteria in the CSF, there's what's called an inoculum effect, which makes the antibiotics less effective. These are data on CSF to serum concentrations for a whole variety of antibiotics: penicillin, ampicillin, third-generation cephalosporins, imipenem, vancomycin. I want to point out that in animals, gentamicin gets into CSF pretty well. The human data really is quite variable, anywhere from 0 up to 30% in terms of CSF serum concentration. But if you have meningitis, gentamicin is probably not an optimal antibiotic. Think about how you limit serum concentrations of gentamicin and try to keep them on the trough level below 2. That means so little gentamicin is getting into CSF, even if it's getting in adequately, the concentrations which are there may not be sufficient to kill off the bacteria. So what do we use? A regimen of ampicillin and cefotaxime. Someone asked me about cefotaxime earlier. Or penicillin and aminoglycoside. There's no evidence that's one or better than another for meningitis, although there's theoretical argument for use of cefotaxime because of its penetration. For gram-negative meningitis, we often use cefotaxime as our second antibiotic, or meropenem if there's resistance. For gram-positive, for GBS, we often use a combination therapy because of synergism between ampicillin and gentamicin for killing group B streptococcus. And that's exactly what this slide says. If there's group B streptococcus or listeria or enterococci, combination therapy is recommended until the CSF is sterilized. We treat gram-positive meningitis for 14 days. Gram-negative meningitis we treat for a total of 21 days. Interventricular antibiotics have not been looked at except in one study showing that the mortality rate was higher in babies who received intraventricular antibiotics, and the Cochrane review from 2007 says further trials are not justified. If we have a shunt infection, we use intraventricular antibiotics, but other than that, for routine meningitis, we do not. And then the last clinical question, should there be a repeat lumbar puncture? After you start, when do you do your next lumbar puncture? And the only data I found is this retrospective study from people in Cincinnati. It's a retrospective observational study. They show that infants who actually ended up having repeat LP were more likely to die, maybe because they were sicker. Repeat LP to look at protein and glucose and white blood counts is not useful. And they felt, in terms of recommendation, repeat LP after 7 days should be considered for infants that are not responding to treatment in the expected fashion, or in infants with fungal meningitis, or those with meningitis due to gram-negative organisms, where the duration of treatment is often calculated from the day of sterilization. So in conclusion, meningitis is, I have to tell you, is a devastating disease with poor neurological outcomes. Improvement of outcomes from this disease will result from finding a way to decrease the risk of sepsis, better ways of rapidly identifying affected babies, and I think most importantly, a better understanding of the mechanisms responsible for brain injury. And with that, I'll stop and thank you for being so patient with me, 2 lectures in a row. You deserve an award. Thank you.
That were not suspected by the junior